Well, firstly, I'd like to thank Sue for inviting me to speak this evening. My name is Catherine Kelly, as she mentioned, and I'm a final year medical student at the University of Dundee. And as Sue mentioned, I completed a Bachelor in Medical Science 2 years ago in International Health, during which I completed this project and dissertation surrounding the use of Entonox in obstetrics, with the issue of sustainability being at the core of this project. But I do touch on some of the kind of issues that Wendy mentioned as well about the occupational risks which exist as well. So to give you a little bit of a background regarding why we undertook this study, in 2008, the Climate Change Act guaranteed a 100% reduction of the UK's carbon emissions by the year 2050 against a 1990 baseline. Now, as some of you may be aware, the NHS is the largest contributor to these emissions of the public sector, which means that it has a major role to play in the achievement of such targets which were set out in the Climate Change Act. And as Wendy mentioned, anaesthetic gases produce 5% of acute organisations' carbon footprint, with nitrous oxide and desflurane being the greatest culprits for this negative climate effect. A 2020 paper suggested that a vital measure anaesthetists can take is to try and avoid using these anaesthetic gases in order to limit their carbon footprint, as 1 tonne of nitrous oxide has almost the same global warming potential as 300 tonnes of carbon dioxide. Now, as you're all aware, nitrous oxide is used regularly in childbirth in the form of Entonox, which is a 50-50 mix of nitrous oxide and oxygen. And essentially, my study endeavoured to gain an understanding of the current perceptions surrounding its use. So this project was structured using an adapted human factors framework, which is known as the Systems Engineering Initiative for Patient Safety 2.0. This is the original model, and we adapted that to become the Systems Engineering Initiative for Sustainable Healthcare. The use of this framework enabled a focus on the system design of Entonox use and the way it impacts the process and its outcomes, as we understood that the use of Entonox is a complex system which needed understanding before attempting systemic reform. So the overall aim of this study was to identify and evaluate the system in which Entonox is used in the Scottish hospital studied, using the Systems Engineering Initiative for Sustainable Healthcare framework, which, as I said, is an adapted human factors model. More specifically, the study hoped to identify the work system factors which act as barriers or facilitators to Entonox use. It aimed to explore alternatives to Entonox and how they are perceived by obstetric staff, to identify perceived outcomes for patients and their families, obstetric staff, the organisation, and the environment. And finally, we hoped to provide recommendations for reconfiguring the current system for potential future change in Entonox use. I'll now give you a brief overview of the methodology that was utilised in this study. The project was registered with and approved by the Theatres, Anaesthesia and Critical Care Clinical Governance Group, that's a mouthful, in the studied NHS board, and that was in order to permit staff interviews. It was a qualitative case study which used document analysis and semi-structured interviews. And the interviews took place with 10 midwives and 1 environmental manager. The recruitment of midwives was initially initiated via email invitation. However, in reality, most midwives participated in the research due to word of mouth. Each interview lasted between 14 and 30 minutes, and they were all based upon a common question guide, which consisted of mainly open questions. The data analysis used a mix of deductive and inductive thematic analysis on the documents and interview transcripts, with the factors of the SIPS 2.0 framework acting as the main themes, with their emergent sub-themes becoming apparent during inductive analysis. Inter-rater reliability between researchers was used to reduce the bias, with the kappa score of 0.725 being calculated, which can be interpreted as substantial agreement between researchers. Now, onto the results. So, shown in this image are the results gained from the document analysis and the analysis of interview transcripts. In the middle circle, you can see the SESH themes, which were taken from the SIPS 2.0 model, and the sub-themes are indicated in relation to each of these themes. The sub-themes that we found were based upon recurring statements which came up in document analysis, in the interview transcript analysis, or in both. So at the center of the circle there, you can see the person, and the sub-themes that we gained in this theme were midwives' knowledge, women in labour, others identified within the system, and staff occupational health. With regards to the internal environment, we've got the location of use and the ventilation and scavenging which is available. With regards to the external environment, we have midwifery training, external education, environmental wokeness, and protocols and guidelines for safe Entonox use. Tasks that we identified were the patient's use of Entonox, staff tasks with Entonox, such as setting up and teaching patients how to use Entonox, tasks which involve sustainability more generally, and tasks involving other analgesics. And then the tools that we identified were Entonox as a tool, a potential new mask, which Wendy touched upon, the double mask, which is thought to be better for collecting the used Entonox, and alternative analgesics for women in labour. And then finally, with regards to the organisation, the sub-themes were local training, environmental sustainability culture, safety culture, and compliance with documents. So one thing that's quite important to highlight is that the sub-themes about occupational health and its recognition in the guidelines which we analysed were recognised in the document analysis alone and weren't identified by midwives in the semi-structured interviews. And then I've attached a couple of quotes which reiterate sentiments which were brought up in several interviews surrounding the use of Entonox, with one midwife saying that sustainability isn't really something that's discussed, to be perfectly honest, so I couldn't say that I know an awful lot. And another that a lot of women would really struggle to not get Entonox because it's such a cultural thing. These outcomes were gained as themes from the semi-structured interviews, and they were vital in giving an understanding of midwives' perceptions of the effect that Entonox has on different elements of the system. It also gave us an indication of how likely or willing midwives were to change their use of Entonox based on their knowledge of its poor environmental impact. Now, this slide shows some pertinent quotes from several midwives which relate to the key findings, which I'll discuss over the next few slides. So with regards to autonomy, one midwife highlighted the vital aspect of maternal choice. With regards to sustainability, one midwife made the point that even the most basic environmental tasks aren't occurring on the labour ward or in the midwifery unit, which inferred that undertaking these tasks is necessary prior to trying to reform the system with a reduction in a widely used pain relief that's really important for women in labour. Another midwife highlighted just how painful labour is, and she therefore wouldn't deny a woman analgesia in the form of Entonox purely for the reason of environmental sustainability. And then with regards to occupational health, one midwife felt that knowledge of detrimental health effects would deter her from wanting to encourage the use of Entonox for a woman. However, at the point of the interview, she did not have any knowledge of such occupational effects which were possible. And then finally, another midwife believed that knowledge of occupational health effects was unlikely to deter women in labour themselves from using it as a pain relief in their labour. From the results that we gained, some particularly important discussion points were gleaned. Facilitators and barriers towards Entonox use were identified, and these are shown in the diagram on the slide here. The facilitators of ease of use, Entonox's safety and short-term effects, and the aspect of maternal choice currently have greater force, according to midwives, than the barriers which were identified as the side effects of Entonox and its occupational and environmental effects. Furthering this point, many midwives were not aware of such occupational or environmental effects prior to the interviews taking place. Alternatives to Entonox do exist, which I'm sure you're all aware of. However, there is not a comparable analgesic which is as easy to use with such rapid onset and offset. The midwives I spoke to had a lack of knowledge surrounding Entonox risks, which inferred that the organisation were not providing sufficient education at this point about such risks. And finally, there were discrepancies between the analysis of documents and of the semi-structured interviews, in which the guidelines provided information regarding the safe use of Entonox, but none of the midwives mentioned these when discussing its use during the interviews. This highlighted that more could be done to ensure that the midwives in this health board are aware of the guidelines which are in place. Results of the analysis gave us the opportunity to create some recommendations regarding the use of Entonox. Senior management within this health board must lead by example to create and enable a culture of sustainability within the organisation. And if we are to effectively reduce the use of Entonox, it is vital that healthcare workers' knowledge of its risks improve. More research into the installation of an Entonox destruction unit, which is already used in Sweden and has recently been trialled in some UK hospitals, would allow for continued use of Entonox whilst greatly reducing its carbon footprint. It also became apparent through literature searching that further research potentially could be required to truly understand the occupational effects which are potential of Entonox on midwives. And finally, a need for sustainability culture has been recognised, and therefore more research could be conducted to understand attitudes within the NHS towards sustainability a bit more generally. In conclusion, a reduction of Entonox in the current system that we studied was an undesirable outcome for both midwives and for patients, but would be a desirable outcome in terms of environmental and occupational health. Therefore, more work is required to either find an alternative which could work to replace Entonox, or the introduction of catalytic cracking would allow its continued use with a much reduced environmental impact. Thank you very much for listening to my presentation. I hope that it's been of some interest to you, and I'm happy to take any questions that you may have.